All right, we'll go ahead and get started. Can you guys hear me okay? Whether you want to or not, thanks. Hey, thanks for all you guys coming in and spending an hour of your day with us. My name is Luke Aurner. I'm the Michigan Region 6 Healthcare Coalition Coordinator. And today, Katie and I will be presenting on the benefits of a dedicated medical coordination center and the incident command structure. This is my co-presenter, Katie Puskar.
I'm with the Michigan Department of Health and Human Services, and I am the Region 6 liaison for our office. So we have no conflicts in this presentation.
But I do want to say one thing, that the opinions of Region 6 leadership, me, are mine and not of anyone else's, including possibly the rest of the state healthcare coalitions. We do things a little bit differently in Region 6, as some of my Region 6 folks, Michigan Region 6 folks in the crowd will agree. So this is who we are. You know, we are the people that are like you, front lines. We lived through COVID all together, and we tried something different, and it kind of worked.
So, little interaction for today. What is one of the most common things that comes up on an AAR as far as gaps?
You win!
Hey! Look at that. And that's why we're here today. We're going to talk about how some of the issues that we had and how we pivoted to make them a little bit better, and how we're continuing to adapt and grow just to make it more functional. Because the way it was working wasn't working. So, kind of what we're talking about. We've all exercised. We've all done communication drills. We've all done all of the things that we have to do per ASPR. But nothing ever happens like we exercise, right? I think we can all agree on that one. I mean, look at what we've learned from COVID so far, the response. Look at all the additional things that have happened in the interim. Doesn't always go as planned, and that's okay. That is okay. As long as we learn from those lessons, as long as we look forward, what can we do better? Keep pushing. That's going to be kind of the theme throughout this. None of us are perfect, including me, as much as that pains me to say. It's a thing. I'm human. You're all human, I think. And so with that, how can we be better? Now the boring slide, objectives, kind of how we work together. We kind of have an unusual relationship. I like to call him my annoying big brother. It's okay. My husband knows me, or knows him. We talk a lot during dinner time.
Hopefully
we make dinners together. It's a thing. That's all right. Love you. Love you.
So why we're here is ultimately just communication. First thing that fails, we all agree, communication. So what we decided in Region 6, and when I say Region 6, of course I am meaning just Michigan Region 6, because I know there's a lot of them out there, is just global communication. So global communication and centralized communication, coordinated communication, is not a new concept. It was not invented by ASPR. It was not invented by any one person. And it's used across the globe. Federally, this is the CDC. This is their Emergency Operations Center. In a state, this is the CHEC in the state of Michigan. This is when they were active through COVID before mask mandates. Locally, you know, emergency managers have EOCs, Emergency Operations Center. And this is Newaygo County Emergency Management Center in my region. Worldwide, NATO has an Emergency Operations Center. This is NATO STRATCOM. Okay? So a lot of different organizations, high-level, multi-function organizations, understand the importance of global coordinated communication. And even private companies like universities. This is Oklahoma State University's Emergency Operations Center.
So I know Luke handed out an acronym, CHEC. We all love our acronyms. So this is the Community Health Emergency Coordination Center. So it's a group of us. It's a group of us within my office that realized years back that the State Emergency Operations Center didn't have all of the pieces that they needed for disaster. They realized it was missing a medical component. And so that's actually where my office works alongside, and sometimes within, the SCOC. And so with that, we can bring some of those expertise, those extra pieces, and those can include state laboratory, epidemiology, as well as a number of subject matter experts, immunizations, pediatrics, long-term care facility, you name it. It's embedded in our office, which has really been beneficial because we can have that one voice. We all come together, we all bring our information to one place so we can get that message out to the public. Because ultimately, that's what the role at the state of Michigan is, get that information out. And that information that we're holding on to with all that expertise isn't gonna help the facilities, isn't gonna help the regions. I mean, who wasn't scrambling spring of 2020? Maybe still now, who knows? But with that, it was at least a place where questions could come.
So at the Region 6 Medical Coordination Center, we dedicated a space for coordination. It's located at our regional offices. It shares a room with our conference room. And this picture, it's before mask mandates, but this is the COVID response. Just a little overview in the back. There's 4 positions. We have a dedicated communications position, and it's flexible to meet the needs of the region. It's not command and control, as we all know. However, there's enough capability there and enough services within that room that it can augment command and control if needed. Its primary role, situational awareness, coordinated communications, and to be a source of truth for information that became so vital during the COVID pandemic.
So, how did we get here? Didn't happen overnight, sorry to say. It takes time, it takes effort, it takes outreach. We were pretty fortunate in Michigan back in 2002 when that original HRSA grant came out that really started preparedness. It happened after 9/11, was put into place as far as making sure that we have some sort of connectivity. We can't just have hospitals doing their own thing, because they have to work together. How many times does one hospital go on divert, and so ambulances have to go to a second facility? Or you need to offload because of an incident at a facility. And so having that connection piece was missing. And I think we all realized that pretty abruptly that day. Now in Michigan, we started out pretty lucky. We had some very smart people who kind of started this whole thing for us. We actually started with the one coordinator and a part-time medical director for each of the regions. And so from there, obviously it's grown. A lot more projects, a lot more responsibilities, a lot less funding. With that, we've been able to adapt and grow and do some extra things. How many new partners do we all have? Long-term care wasn't really even on the radar for a lot of people until COVID hit, or not to the extent that it is now. So we've been able to kind of grow from there. One other plug for original leadership, they actually made the boundary lines the same as the state emergency management, so that way we could work together uniformly. So that way we could embed that emergency management into our operations, in with the regions and things of that nature, rather than having to speak 2 different languages, having to draw different lines of, well, you're in this one, but not in this one. They just decided to make them the same, and I think that was one of the brightest decisions they could have ever made. It's been very helpful. And as mentioned, we're still growing, we're still learning, we're still adapting. So, I didn't think you probably didn't realize you're gonna get a geography lesson here today, but give you a little understanding about Michigan's breakdown. Now, before you go too much further, we don't talk about Region 4. A lot like Bruno, it's a thing. Don't know why, we don't have a 4, but we have 2 number 2s, north and south. We're right next to Disney, why not? So with that, you can also see, geographically speaking, there are some very, very small regions. There are some very wide regions. If you look at 2 North and 2 South, the 2N, 2S, those 2 regions, 6 counties, make up nearly 50% of Michigan's population in 6 counties. So you can imagine what they're dealing with there, versus the entire Upper Peninsula is 1. Now that has its own challenges because of distance, weather. It's also one of the reasons why we're here. Weather report back at home, it was 36 degrees and snowing. So with that, one other thing that I want to point out on this map. With this map, Upper and Lower Peninsula, there's no land connection between the 2 within the state of Michigan. The Upper Peninsula is land connected to Wisconsin. Love our Wisconsin people. With that, there's a 5-mile long bridge, suspension bridge. That's 200 feet up off of the water. So we're talking big bridge, long bridge, subject to winter. Further north that you go, that bridge gets shut down several times every winter. I get the alerts. That creates a unique challenge to Michigan, having that peninsula. With that, we also realize that we have to plan even further ahead. You don't know what the weather's going to be like. You don't know what bridge conditions will be, because of course over water. You've got ice shears that are falling from the pillars. You've got high winds that can blow vehicles off. All of that has to be taken into account. So kind of unique, but as you can see, we're not small. We're not small. We got quite a few people, a lot of hospitals, 181. Now those do include the acute care, psychiatric, and pediatric. I included all of them. 436 skilled nursing facilities. And last count, it was actually over 4,500 of the other nursing home definition by the feds. That's a lot of people. That is a lot of people that we need to connect with. And a lot of distance from one place to another. So if you drive from the south end of 2 South there, take 75 all the way north and go across, you're looking at nearly a day drive in good weather. So a lot of unique challenges there. Now, I know, everyone groans when they see this screen, but we have to talk about it. With the outbreak, what we had in place wasn't working. I think we can all agree. We had plans. We have emergency operation documents. We have annexes. We have it all. We were not ready for this. I'll be the first to tell you. I don't think we're still completely ready for it at this point. And then there's always that thought of what's next. Are we ready for the next? And I think, again, looking at supply chain and all of those other pieces, we're not ready. Now, I'm not going to go through the whole history, just to give you kind of a brief overview of the beginning. And this is, again, our leadership. As much as I disagree with them at times, and that's okay, it's on record, I'm okay with it, they had the forethought in mind. The point that I want to really emphasize here is February 5th. That's when the check was activated. We had no positive or known positive cases in Michigan at that point in time, but yet they activated us. We didn't get our first official positive over a month later. Now, part of why things started so early and why I am thankful for the extra time and stress and everything that went into it, more than 50% of our office have never been through response, me included. I was new. I've taken all the ICS courses. I know what the book tells me should happen, but that's not exactly what happened. Again, I think we can all agree on that one too. But that bought us a month. That bought us a month to get our feet under us, to understand what the role really was, how we fit in with the picture, how the regions fit in with the picture, and how we can connect together to have that unified front. Because again, messaging, so important. Communication. As much as we hate the media, it's important. Because if they're not going to get it from you, they're going to get it from somewhere else. And once you have that initial information, you're going to be closed-minded to the next thing that you hear. And so, very thankful very thankful that they had the forethought to pull us all in to get us ready. Now, I know this is impossible to see, but we do work with the ICS structure. We modify it because at the state, we're not boots on the ground. That's not our role. Our role in the check is communication. And with that, the biggest modification that you'll see is actually here in the operations section. Finance, logistics, all of that is pretty standard. But the operations section. Within the operations section, which is the largest of the groups here, and it is for our office as well, we broke it into two main branches, public health and hospital preparedness, or healthcare preparedness. And that's actually where we house our epi, our lab, our infection prevention, our testing team, our you name it. So they fall into those. We also pull in EMS. We also pull in several other units that we're connected with, like trauma. They're in operations as well. And that was very, very critical for how we functioned, because we could bring all of those experts to get that information out to one another. And again, having those subject matter experts, I'm not the expert on everything. As said before, I'm human. I have brain restrictions, limits. And so with that, I didn't have to be the expert on everything, but I knew who I could ask. And having that set up in place, having those people already dedicated to that location, that role, maybe not by name, but by title, knowing that they'd come over to our office when we were still in person, and I could ask them, like, what does this laboratory item mean? You're giving me a whole bunch of numbers and letters. What does that mean for me? And then how can I get that to the public? How do I relay that to Luke or Tim or our Region 5 who's sitting right here as well? So 2 North is back here. So with that, how do I get that information in a usable format? That's really my role. Talking to those experts, getting that to a usable piece of information. Now.
And it all comes down to the source of truth. So our MCC activated right about the same time as the check activated. We saw what was coming, and being a 2-person region, coordinator and assistant coordinator, we knew we were going to have to do something. At this point, we didn't necessarily know what we were going to have to do, but we figured, okay, we have this MCC, let's go ahead and activate it. Let's start documenting and figuring out what our hospitals need and what our other partners need. We also set up the incident command structure, and this is our normal regional incident command structure on paper. Looks pretty, right? It looks like it's supposed to look. That's kind of more like it happened. And I know it's very difficult to see, but one would think, for those of you who are coordinators, assistant coordinators, one would think that the coordinator would be the incident coordinator, the assistant coordinator would be the deputy incident coordinator, and kind of everything would fall into there. However, very early on, I made a controversial decision to send my assistant coordinator outside of the office. I sent them to our warehouse. Right about the time that you could buy a pack of N95s on eBay for about $1,000, and we were sitting on a large cache of N95s, I needed someone there I could trust who was responsible for it. So this opened up a lot of different areas. So we brought in extra people, and we'll go through that here in a little bit, but another portion that we had to contend with was our medical director. Now, my medical director is very supportive of everything we do. However, he is a frontline worker. He works in the hospital and is in charge, and at that time was in charge of the emergency department. So although my medical director was available to me, he was slightly busy. So we had to change a little bit of how we did things, making it so that we could make more just-in-time decisions with his pre-approval on certain items. However, whenever it comes to money, we did have to run it through him. So this really comes back to a question. Whenever I speak to someone who says, oh, we can't run a response like this, we're only 2 people. How many people does it take to run a medical coordination center?
And I promise you it's not a joke.
1, okay. 2, how about COVID? How many people, if you look at the true ICS structure, how many people to fill all the roles you want to fill, logistics, operations, PIO, media, everything? Really can't, yeah. Yeah, that's just a question, right? So ultimately, we wound up with a lot of people. Our region truly came together and filled out every single one of these roles. We had fire department chiefs and assistant chiefs. We had PIOs from different organizations coming in and filling the role. We had public health, emergency management, all embedded in our MCC and in our ICS. This allowed us to make real-time decisions with all the players on site. And to this day, we can still ramp this up for all the different types of incidents we respond to using those partners.
So, how does it all fit together? Obviously, we've talked about the state end, we've talked about the region end. Now, in ideal times, this is how it works. We have the governor on top. We have our SEOC, State Emergency Operations Center. We have the CHEC, which is a part of that. We also have our local EOCs and emergency management, medical control authorities, all of those players also embedded in the SEOC in our state. Now from there, as you can see, the straight and full lines, those are the direct connections. The dotted ones are the additional layers of communication. We love to talk a lot, as it turns out. And so with that, it proved to be very beneficial. I knew what was happening in 6 or 5, 2 North, 8, without having to leave my computer station. I knew all of that because they would tell us. They would send that information in to us. Now, beginning of COVID, that was extremely overwhelming, and I will definitely be the first to tell you all of that. But with that flow of information, again, here's just kind of a different look at how those pieces flow. One thing I want to point out about this picture, the arrows, they go in both directions. That's key. You have to have information that goes up as well as back down. Because if you're just having that one line of communication, you're missing pieces. So somebody could come out and say, all right, today we're all wearing blue. And if you have no way to respond to that, why do I have to wear blue? Is there a reason? What information can I give out to the public to understand why we made this decision? Now, we weren't really good at justifying all of that, especially up front with how fast things were coming, but that's the ideal. Give them what to do and give them information behind it, having that expertise behind that messaging. That way, people can make those informed decisions. And so with that, again, a lot of lines, a lot of connections. Now, that didn't work in COVID. With all of the information going into our incident commander, our response commander, that was one person. We kind of modified with 2, but even that. You saw the number of facilities that we have in the state. It was too much. So what we did, we kind of modified ICS a little bit more, and we added the subject matter expert as a lifeline. So that way, now, my role was long-term care. Still is, I suppose. With that, if somebody had a question from a long-term care facility that they couldn't answer, rather than going through the check, through the operations chief, then to me, if I wasn't in the chief role that day, what would happen, they would contact both of us. It would go through our ICS structure in the check, but they would also directly add me into anything long-term care related. That way, the check was aware that the question was there, as well as that I answered. And so that was, in case something happened to me, there was a backup. We could still run through that normal structure, but we didn't necessarily have to do those extra steps, because you know how quickly information needed to come out. You had surveyors at their door, you had fire marshals coming in saying something else. It was a mess. And those things cannot wait for days. And so we were able to pivot, thankfully, to add that extra step, or that side step, if you will.
And this was very important to note that all those questions came up through the RMCC, through the Region 6 Healthcare Coalition Medical Coordination Center, because it wasn't just that one facility that was asking. That same question was being asked by multiple facilities, and probably not like facilities. Hospitals wanted to know what was long-term care was doing. Long-term care wanted to know what EMS was doing. So having that all funnel up through the MCC truly helped not only to give one message, but be the source of truth and really take the burden off of the check and the subject matter experts so they could take the time to formulate the correct answer and not get overwhelmed with a number of same questions having to report out to multiple different organizations.
It also prompted kind of the ability for us to, like Luke said, if Facility 1 is asking that, I know there's at least 7 more who didn't speak up, whether they didn't have time or know how to formulate it into words. And it wasn't just unique to Region 6. Questions were pretty similar across the state, and having that access to all of those, I could see some of those important questions as they came in and was able to spread that out statewide. So that was also a very big benefit. Now, our favorite topic here, media. Love-hate relationship, we all do. We know how things end up, but it's critical. As I said before, people want answers. They want to know information, and typically, they're going to believe the first thing they hear. Now, it's okay to modify that once we have additional information, but be upfront with that. Of, hey, new developing info that has come out from epidemiology. This is how this works now. This is why this works this way. It also allows a consistent message. Because if I say, hey, let's wear blue today, but that's not the focus of those subject matter experts, or relays a bad message, if you will, that's going to fall back on me. What having this PIO embedded into our check operations allows us to make sure everything has been checked. Everything has been dotted, every message is consistent with the most updated information that we have at that time. Again, is anyone here an expert in everything? Exactly. And I'll never claim to be because I don't want that responsibility. So
one tact we took in Region 6 was to make sure to push out consistent information from us, gathering it as one source of truth from MDHHS and getting it out to our regional partners. At this point in time, our regional partners truly look to us for that one source of truth. So we put out media releases. We did news interviews. In the bottom right corner is our medical director, Dr. Jerry Evans, who was on the news quite a bit and continually fields requests from media to be on the news and give interviews on the health topics that are popping up. We have a dedicated PIO that works with us through the City of Norton Shores Fire Department, who happens to be their PIO, who handles all of our media requests, and he comes from media. So it has been a lifesaver, because to be honest, not only do I not have the time to answer all the questions from the reporters, I don't necessarily know exactly what they want.
So a couple of things that we did during COVID. Now, we're not, again, at the state level, we're not necessarily boots on the ground, but we were able to do some pretty incredible things. So we were fortunate enough to get 2 federally qualified alternate care sites to help offload or decompress the hospitals in our larger regions, 2 north, 2 south, each had 1. And with that, there was a lot of work that went into this. A lot of planning. As you can see, that's the warehouse space for one of those 2 alternate care sites. We had that plan in place, and I think you, Region 2 North is laughing at me here. It didn't go as planned. It did not go as planned. But again, that gave us the feedback, the information of what we can do to make it better. That's always going to be the message. What can I do better? What can we do better? And I think that was one of the first times that we've ever set something up, especially that large. I'm getting confirmation. And so with that, we're new. We're new to some of this stuff. I mean, that's half of our office was new to response to begin with. A lot of the coordinators, one back there, in fact, was on for a week before COVID hit. She doesn't know what her actual job is outside of response. And so with that, you know, a lot of growing pains, a lot of learning. But this was one of the major accomplishments that were able to be set up and utilized.
So as they were setting up their alternate care site, Region 6 also set up an alternate care site using our regional supplies. All that information was being funneled, just like that the state's alternate care site was the information was being funneled through the check. Our information was being funneled and coordinated through the Regional Medical Coordination Center, using the instant command structure, using those people, and using our supplies, set up our own ACS. Now, special note, we never housed anyone in it. It was a great exercise in the middle of COVID. However, we never did put anyone in there because it was found that it was not the best option at that time.
Kind of other big event that we put on. So we did a statewide vaccine clinic at Ford Field, so middle of Detroit. We set up with the idea of trying to hit those underpopulated or those at-risk populations, those who maybe were forgotten or couldn't get to a vaccine center. This was set up. There were a lot of travel was involved with this. Some of the busing systems agreed to do free busing to one of these centers. And so with this, it was a massive undertaking because remember, primary series, 2 doses. So not only were there logistical challenges of getting some of these folks to this center, but it was also getting them back in 4 or 5 weeks, depending on which vaccine type that was given. And so we were fortunate enough to have the Michigan National Guard involved with this. As you can see, it was quite an undertaking, a lot of people. I don't remember the numbers exactly, but it was a very significant event and really helped with the populations, the underserved folks. And all of this was within that command structure. It was part of that operations overseeing with the public health branch.
So one point through the COVID response that really stressed our command structure was our PPE distribution. So when we received shipments from the federal government for PPE, it was decided in Region 6, and this is where we differ from everyone else, it was decided that emergency management and the healthcare coalition would combine as one for PPE distribution. So through the Medical Coordination Center, we coordinated all PPE distribution for healthcare entities and anyone getting PPE from emergency management. Now, you'll see here, these are pictures from our warehouse. This had operations level people from National Guard, emergency management, hospitals, public health. Every single partner we had a role in this. At one point in time, we had about 20 people working in the warehouse, picking, pulling, and shipping, and also delivering. But again, Everything came through the incident command structure up to the MCC, decisions were made, came back down, and then reports went back up to the check so they could keep good situational awareness at the state level. So a couple other incidents that the Medical Coordination Center responds to. We had a dam failure, not in Region 6, but in the state. So the Midland Dam failure on May 19th, 2020.
Right in the heart of COVID, the beginnings?
Threatened
Yep.
a lot. It affected one hospital, multiple nursing facilities, and the Dow chemical plant. This could have been catastrophic. We actually were already activated at a lower level because at this point we were virtual, but set up another incident, thinking that downriver from this, that does come into our region, we were going to have to deal with something. Luckily, we did not have to, but the structure was there, the communication was there, and it worked relatively well. And then, of course, we have weather. Every year in Michigan, we have something, whether it's going to be long-term power outage, polar vortex, something. The communication is key. Knowing what our facilities need, knowing what our facilities want, and communicating in a coordinated manner so that we're all doing it as one big group. Now, I'm not going to stand up here and tell you that it's perfect all the time, because it's not. Sometimes it's pulling teeth. However, we try, and we do the best that we possibly can. So we're going to talk a little bit about technology and how technology has changed our Medical Coordination Center, and really how everything has happened through COVID. So when I started way back when I was a young one in emergency services and emergency response, everything was in person. If you had a meeting, it was in person. And then when you come to the beginnings of emergency management, it was still in person. If you had an EOC activation, you had to go to that one spot. And one of our largest facilities in Michigan, now called Corewell Health, when I first started in the region, they had a command center where they met as one big group. But technology and COVID kind of changed all of that. And then we had this balancing act of, well, we can't really meet in person any longer. So what do we do in person and what do we do remote? So in Region 6, when we had to go remote, we relied heavily on technology. We embraced technology. Luckily, we had the forethought to purchase good technology upfront. Good, powerful computers that could run multiple meetings that would not crash when you're on one instance of a Teams or video chat and running other programs at another time while in a remote location. We leveraged we used Javari, EM Resource, EM Track, EICS. In our office, we had a subject matter expert in it until he was stolen by the state. And he's sitting in the back of the room. So we were able to leverage that to have using those programs to have good situational awareness, all while we were remote, and really stay connected. So some of the pros of technology is that we could add people to those meetings as needed. We've all been there. You can sit down at your computer and be talking with someone and say, we should really loop this person in. Well, let's just call them, right? And now you have a face-to-face, although no one likes to use cameras.
Except for him.
Yeah, and Rick. And there's no travel time. There's no cost of travel, right? No more are we having with technology to travel a long distance to go have a 35-minute meeting to then have a travel all the way back to your office. It's just a click of a button. You can reach larger crowds. I mean, how many times have you had a meeting with 150, 200 people on it? All right? Where could you find a space for that except for in here? And it's easier to multitask. And anyone in here can't tell me that they don't multitask when you're on one of those virtual meetings. It's like, no, I'm listening, right?
Wait, can you repeat that?
Yeah, right. But a con of technology that we found it is easier to multitask, as my assistant coordinator pulls out his computer. And the meeting fatigue. How many meetings can you realistically have in a day? I mean,
And absorb them,
Right.
absorb the information.
I mean, 8 hours, 16 meetings. That's not unheard of. We also found that there was a learning curve to technology. We found that not everyone embraced technology as much as we did. So when you ask them to join a call, well, what's the phone number? Well, no, it's on your computer this time. Well, I don't know how to do that. And that took a little bit. Now it's getting better, right?
Or the mute button.
That darn mute button. Technology is also very dependent on power and internet connections. So as we move forward, we have to really look at our critical infrastructure and say, well, if we're going to meet as a group remotely, are we going to have the power and the internet? And then there's the human contact. It's that inflection that you get from their face when you say something sarcastic, which is every other word out of my mouth. Are you being serious right now? No, I'm not being serious. Really, I do want to have a 5-hour meeting. So in Region 6, our remote work had to be very flexible. And the instant command structure for remote work had to be adapted for this. Because again, instant command structure was truly developed to be able to walk over to someone and say, can you please do this? We also found that although it gave us more flexibility to do a lot of things, we needed to have those communication backups, and everyone needed to know the communication backups. And then there's the expensive technology versus the expensive space. So on FEMA's website, and I don't expect you to read this, but I just wanted to put it out there. On FEMA's website, they actually have a virtual EOC best practices document and site. And it actually shows you what things you can do as best practices for being remote in an instant command structure and a coordinated communication arena. So I threw this up there because we're talking about technology, and one really strong point, and I can only speak to Michigan, is that we do get a lot of data. Now, data is the bane of our existence when it comes from a regional level. However, what we get out of it at times is pretty great. This is a dashboard, and this is a great situational tool for communication of current situation based on the data everyone is reporting. Using this in the instant command structure and through our medical coordination center is an easy way to communicate needs, wants, and situation. So we're going to talk about some challenges that we found. One of my biggest challenges is the sharing of documents and the firewalls through healthcare systems. We are a nonprofit. We have our own IT department. I'm the IT department. So when I try to coordinate, communicate, or just simply share a document with some partner facilities, it's blocked. They can't access it. And it's still a challenge today. Earlier this morning, I responded to an email from a hospital CEO that said, our firewall won't let us get to your website. I'm working on it. The website's been up since I started. And that's where we house a lot of our information. So it's just little things like that that we found to be a huge challenge. And then again, the knowledge and the expertise in accessing it. I cannot tell you how many times people said, well, I can't get it on my phone. Well, I need you to go on a computer and look at the document. Well, I don't know how to do that. I can only do it on my phone. So it's little things like that that I've never really thought of going into this. But some tips and tricks that we found were to use forms, all kinds of forms. Now, as my hospital partners and my long-term care partners would probably tell you today, they hate the amount of forms I send out. Surveys, forms. If you want something, please fill out this form in triplicate and send it to us. It's not in triplicate, but I do want the form. This is because we need to document it. And we found that the ICS forms were perfect. They're a little daunting. You can make them fillable. You can change them a little bit with Adobe. However, they work. And every single time we did a meeting in the MCC using the instant command structure, we used the forms. So a couple other things that we use in the Medical Coordination Center to monitor is TweetMap. Because apparently there's something called Twitter, and people use it a lot. And believe it or not, half the time you will get information off of this before you will get it off of anything else, specifically accidents, road closures, that kind of thing. Now through COVID, yes, we watched it. However, it wasn't very prevalent. This more comes into handy for weather, power outages, road closures, huge accidents. The National Business Emergency Operations Center has a lot of documents, and it has a dashboard that you have to sign up for. We monitor that. They have news articles that come across their feed and just things to watch out for. National Weather Service, well, that's the wrong picture. National Weather, wow, the pictures are weird. National Weather Service is something that we monitor, and Google Maps. I don't know where all of my pictures went. There are all my pictures. So National Weather Service down on the right, Google Maps on the left for monitoring traffic. Why would I care about traffic from a medical coordination center? What? Transportation. Resources. So if an MCI came in, and this was taken a couple weeks ago, you can see the city of Grand Rapids right here. And this is a highway that's closed. I know that if I'm trying to pull, or if I have an MCI in Grand Rapids, and I need to pull resources from Holland, that those resources might be delayed. So I might suggest to Instant Command on site or the ambulance service in Grand Rapids that they might want to request something from down here on the other side. Our job in the Medical Coordination Center is to help our partners. It's to be that extra person, to be the source of truth. And then our website.
And not just their website, that one there, that's the state website. So early on in COVID, we realized the importance of having all of that documentation, resources, quick sheets, one-pagers, you name it, it all can be found here, as well as all the data. All the publicly posted data ends up on this one site. So all we had to do was link people to that site, and then we put that link on all of the other pages if they happen to go there too, but it would all circle back to this one page. One and done. Makes it a lot easier for people.
And we house all of our documents on our website also, except for the one hospital that can't access it. And then there was supposed to be something else there, but the future. What does the future look like for us? Well, coming to this conference, I don't know. There's a lot of talk about mocks. There's a lot of talk about regional coordination. But no matter what, it's all going to take partnerships and coordinated coordination. Now, I'm not going to stand up here and tell you that I know everything that there is to know about the response in our arenas. I have a pretty good handle of Region 6. Don't take me out of my boundary because I won't know. I'll have to look at the little flip book that they have. But in Region 6, I'm pretty good. And I can tell you what we need. And we have it. We have coordination, communication, and cooperation. Most of the time. So we're going to open up for questions. Yes?
How do we staff the branches in your operations section?
That's a great question. So,
Why don't you repeat the question for those?
oh, I'm sorry. How did we staff the operations section in our MCC? So we had a lot of volunteers. We used the Michigan Volunteer Registry. In the beginning of the slideshow, you saw 2 people sitting at a desk. They were 2 volunteers that dedicated time for 8 weeks straight. Was that right? 8 weeks straight, Monday through Friday, from 7 a.m. to 5 p.m. They were probably some of the best volunteers I've ever met. They were awesome. And they did our phones. Fire chiefs, fire department personnel, EMS heads, long-term care, public health representatives, emergency management representatives, and National Guard were all assigned to us, and we pushed them out as appropriate. CERT also came in and did it.
And I was technically part of that as well, being the Region 6 liaison.
Because I'm assuming some of the work that we're doing involved like making clinical decisions about which patients go where.
It was not. So we did not do any load balancing. That's a very interesting conversation in my region. Load balancing is not something that the regions in Michigan currently do. It's definitely being talked about. However, currently it's not there.
All of those people that you mentioned were volunteers.
All volunteers. The fire departments, they were paid. They were salary or hourly, donated by their individual departments. CERT team and the Michigan Volunteer Registry, they were all volunteers. We gave them lunch and snacks, all the soda they could drink. And coffee. Lots and lots of coffee. We had 1 contracted staff. Technically 2 because our PIO, we contracted to do some technology stuff, but we had 1 contracted staff to do logistics. Especially when the logistics of the PPE increased. We ultimately just don't have enough time to go into the PPE side of it. However, using Tim's guidance, Tim's up front, he's my assistant coordinator, he was able to run that section where it was basically its own internal instant command structure, very loose. So, yeah.
Do you have an MCC in each one of the regions?
Technically, yes. I am the only one with a dedicated MCC.
Okay, thank you.
Yes. So, just so I heard you correctly, who does the distribution of? So the state actually handled most of it. So what we did was we didn't do anything with vaccine. Public health, through the check, handled all that, and I'll let Katie talk on that. At the regional level, we did and do handle a lot or some of the point of care testing, but it's only the emergent point of care testing. So we have a very small supply, and if a facility, such as a long-term care facility, calls and says, we are out, We cannot get any more. We will help them until they can get their supply back in. Do you want to talk about the vaccine?
And as far as the vaccine, Luke was right. That was handled at the state level, mostly through, lucky to have a immunization division within the Department of Health and Human Services. They worked with a lot of that distribution. We did also, at least the long-term care facilities, originally partnered with the public entities. I think that was nationwide. And so there was that effort. There was also big push, and the thing that we really wanted all medical facilities to move towards is to become their own vaccine providers. And so what we did is pushed all of that. A lot of that was actually run through the local health departments. So they would get the main shipment, and then those smaller pieces of distribution were at the local level. And so we kind of put the pieces in place and let the people who were on the ground and right in the middle of it really work out the details, and that worked well for us.
Yes, in the back.
Were you on with information sharing solely to healthcare, or was that all? I'm assuming maybe the health department was also communicating with healthcare for vaccinations and stuff. And I'm just curious those two ways, especially like when you talk about communicating all the way to all long-term care and healthcare. Is it email? Is that what we're talking about?
Email, meetings. So like many of you, we had, at the height of COVID, we had daily meetings. Hundreds of people on it. Then we scaled back to a couple times a week, then weekly, then a couple times a month. So a lot of it was by email and posting it on our website. We found that our website was a really good spot for information, just to dump information. We produced a quick sheet that we called it, 4 or 5 pages, rotating information, updated, staffing solutions, where to get testing supplies. One big thing was fit testing. So a list of where to get fit testing. I convinced a company that they should go do on-site fit testing, so that was a service they started. So that's how we shared a lot of our information. But honestly, a lot of our information went over phone calls too.
Yeah.
We made a lot of phone calls, especially talking some facilities off the ledge, saying it will be okay.
I have one more communication with the arrows going up with state level decision making, maybe specifically around any scarce resources. Were you at all involved in those conversations? Did you have a direct liaison in any way to know what state leadership was deciding or what you needed?
Absolutely. So I'll speak from my side. The communication from the region to the state is unprecedented. I can call anybody at the state at MDHHS on our side, from Katie all the way up through our HPP manager, the person above her, and the person above him at any time with any question. The check, once it was activated, has a duty officer. That's a 24-hour number, 24-hour email. I regularly used it. And one of the reasons we were successful is because we had that communication back and forth.
Yeah.
We were able to make our decisions on site, but as soon as it overwhelmed our resources or our knowledge, because COVID was a lot about knowledge, especially with the ever-changing information, I had that resource to then push back out. So probably at least 3 times a day I was on the phone or getting an email saying, this changed again, and then that went down to the individual partners.
And as I mentioned, we made dinner together a lot, especially at first.
On the phone.
On the phone.
No, really. It changed yet again, back to what it was. Any other questions? All right, I really want to thank you guys for spending the last hour with us. Have a great day and enjoy the rest of the conference.